Okay, last chapter. We're going to talk about chapter 20. This is the newborn at risk. This is what could happen to our babies that has risk factors, or either gestational while they're inside mom, or acquired, something that happened along the way in pregnancy. So let's get started. Let's talk about variations in size and gestational first, and gestational age, and the variations in size that newborns can be. So most of our newborns are born around 40 weeks, and usually their weight is anywhere from 5.5 to 10 pounds. Now, when you're pushing the 10 pounds, you're going to be at risk for, larger gestational age, but this is what majority of newborns are going to be, 5.5 to 10 pounds. They're usually going to be 18 to 23 inches in length. Now, if there's variations in this, if we have a baby littler or bigger, that's going to increase the risk for perinatal problems, or while pregnancy problems, or birthing problems, or something's going to happen. So if we have a variation in weight or length or head circumference, we're going to call those like small for gestational age, SGA, appropriate for gestational age, AGA, or large for gestational age. So we're going to look at those types of things, and that's going to be our manifestation of what they're going to look like. So if we're doing our variations based on weight, then it's going to be low birth weight, very low birth weight, extremely low birth weight. So can you see the difference? I'm trying to go backwards to show you. Here we have small for gestational age. This is gestational, so if you've got a 38-week gestation mom and baby should weigh 5.5 pounds and baby only weighs 4.2 pounds, that's going to be small for gestational age. So going to our variations based on weight, low birth weight, very low, or extremely low. So newborn classification is going to be based on our gestational age. So how do we classify our newborns? We're going to be preterm, post-term, or term. That's the three things we're going to have. So if they're preterm, they're going to be born less than 37 weeks. If they're post-term, it's going to be greater than 42 weeks. A term baby is 37 weeks and like 7 days to 42 weeks gestation. So that is term. Anything less than 37 is going to be considered preterm. So if you've got a mom that comes in and she's 37 weeks and 5 days, they're going to consider her term. If she comes in and she's 36 weeks and 7 days, that's less than 37. So that's going to be preterm. Okay, so gestational age assessment. So gestational age assessment is usually going to be that evaluation in those first few hours after birth. So remember we talked about as soon as the baby's born, we're going to worry about respiratory, we're going to worry about thermoregulation, we're going to worry about blood sugar, cardiovascular status, all of those kinds of things. But once the baby's born, we need to kind of establish where their gestational age is. Now, I was recently at Carbondale, and they have stopped doing Ballard scores unless they have a mom that comes in and they do not know their gestational age. Most of the time, if they've been going to prenatal visits, the doctor knows their gestational age because he's been following that mom throughout their pregnancy, and he kind of knows what the gestational age is. However, if a mom comes in and she is in labor and she has no idea when the baby's coming, that's a whole different thing. So we have to do something called a Ballard score. And two things that we look for in a Ballard score is neuromuscular maturity and physical maturity. So if you think about neuromuscular maturity, think about nerves. So that's going to be our reflexes. Muscular is how well things are moving. So you're going to look at a few things with that neuromuscular. You're going to look at posture. You're going to do all kinds of things with their arms. You're going to look at different kinds of things because that's neuromuscular. Then you're going to look at physical. This is what you're going to see. So what does their skin look like? Is it peeling or is it translucent? Do they have a lot of lanugo or do they not have any lanugo? Do they have those plantar creases on their feet or do they not have any? Are their feet peeling because they're over, they're 42 weeks? Do they have breast buds? and you're going to look at the eyes and ears, and you're going to look at the genitalia. Those are the major things that you're going to look at. So there's two categories that we do for Ballard score. We do neuromuscular, and we do physical maturity, and we give them scores on that, and that will come out telling us a gestational age. So let's talk about small for gestational age. This might be growth restriction. Maybe the baby hasn't been able to grow like it needs to be growing. So this is an infant that's born smaller than the average size. This is going to be in weight, length, and head circumference for whatever weeks that they've identified them to be. So usually we can identify that early based on ultrasound. Sometimes we get what we call intrauterine growth restriction, which we've talked about that way early in this course, but for whatever reason the baby's not able to grow like it should. So we got to figure out intrauterine growth restriction. Why is that baby not growing? What is the underlying condition that's bringing that baby to where they are? So a lot of times it's going to happen if that baby can't receive oxygen and nutrients that are going to be necessary for proper growth and development for their organs and their tissues. So sometimes that can be a placenta problem, sometimes that can be a mom problem, sometimes that can be a vessel problem. Lots of different things can cause small gestational age. So we'll talk about those here in just a minute. So this is if their weight falls below 10% of 2 or 3 of the categories. That's how we determine that. But contributing factors. So what kind of contributes to this? It's for whatever reason there is interference in the supply of nutrients to the fetus. It might be inadequate maternal nutrition. It might be an abnormality in the placenta or its function. Sometimes the placentas are meant to go for 40 weeks gestation. That's what they're meant to do. Sometimes those placentas start to die off a little bit and they're not delivering the nutrients and things that they need. That's placenta insufficiency. It's not giving what it needs. Sometimes it can be maternal factors, things that the mom is doing. Maybe it's lifestyle choices. Maybe she's a smoker. Maybe she's doing some drugs. Maybe she has a chronic disease that's been going on with it. Maybe she has like diverticulitis. She has Crohn's. She has a malabsorption disorder that we know about. Maybe it's genetics, demographics, where they live. Maybe it's pregnancy related. And then fetal factors. These are things that can be wrong with the baby, causing it to be small for gestational age. That might be chromosomal abnormalities, congenital defects, hemolytic disease, infection, all kinds of things like that. So a lot of times if you see a doctor and they're like, the mom's 38 weeks and the baby's just not growing, they'll say, we're going to go ahead and induce for the safety of the baby. Because they feel like if the placenta's not doing what it needs to be doing, or there's a maternal factor or a fetal factor, sometimes we can take care of that baby outside the uterus better than we can inside. So what are you going to see in small for gestational age? You're going to see symmetrical growth restriction. So symmetrical growth means everything's going to be symmetrical and grow symmetrical. So 20 to 30% of all newborns' weight, length, and head circumference, all of that will fall below the 20th percentile. This is more serious, and usually that's a genetic cause. And we'll have to figure out what genetic cause that is. That's when their weight, length, and the head fall below that 20th percentile. Everything is symmetrically small. Asymmetrical growth restriction, this is where most of our babies, our small for gestational age babies, are going to be. 70 to 80%, their head is large in comparison with their body. One or two measurements fall below the 10%, but not all of them. That has a better outcome than the other one. So clinical manifestations, what are you going to see? They're going to be kind of pale, thin, they kind of look real skinny, their skin's going to kind of be loose. It might be peeling off, there might be very little vernix, their face is going to look kind of shrunken. There might be some neurological involvement, things like that. The genitalia are going to appear less mature. The umbilical cord might be kind of thin. There might be meconium staining, especially if baby's been stressed. When babies get stressed, they tend to have their first bowel movements. So what are some complications? Now we have a mom that's came in, we've determined that she is small for gestational age, so what do we need to anticipate at delivery? Well, there's a good chance that baby might have hypoxia. Maybe they've aspirated some amniotic fluid. Maybe they got meconium staining. They got meconium aspiration syndrome. We might be thinking that this baby might have to go by C-section. They might have difficulty going from that cardiopulmonary transition. So there might need, their APGAR scores are probably going to be lower. We're going to probably have to do some more interventions to get that baby going. Thermoregulation, they're probably not going to be able to regulate their temperatures very well, so we're going to have to keep them warm. Hypoglycemia is going to be a big thing. Respiratory distress, polycythemia, they've developed a whole bunch of red blood cells. So what are we going to do? Biggest thing we're going to do is monitor that respiratory status. If they're not breathing good, we're going to have to intervene right away. Maintain that thermal environment. Normal babies that are born, their thermoregulatory system is very immature. It hasn't gotten developed yet, so it's very immature. And in these guys, it's going to be even more immature, more important that we keep them warm. We're going to have to monitor those blood glucose levels very closely. Monitor their blood status. Observe their feeding tolerance. If their respiratory rate is over 60, we're not going to be able to feed them orally because they can't suck and breathe at the same time. So aspiration is going to be a higher concern. Monitor their I&O very strictly. Daily weights on these babies. Look for jaundice. Encourage your caregivers to come and see the babies and look for the babies. Large for gestational age. Okay, this is where the weight, length, and head circumference is above the 95 percentile. So full-term large gestational weights are more than 8 pounds and 13 ounces. And they have to have that in 2 or 3 categories above that 90 percentile. So it has to be 2 to 3 in weight, length, and head circumference. Generally, our large for gestational age babies, they're proportional. Their head and weight fall in the upper limits of those growth charts. So we look for that. Most are genetically or nutritionally adequate. So most of the time, genetics are going to be okay. Nutrition's going to be okay. So we don't have that to worry about like we do with the small for gestational age. Sometimes we get a large for gestational age baby because we just had a little bit of miscalculation on dates. So that's always possible. So what are we going to see? Well, we're going to see the underlying cause for large for gestational, it might be unknown. Biggest one that we're going to see, mom has gestational diabetes or mom has maternal diabetes type 1. Maybe there's a genetic makeup. Maybe every baby in that family has been large. That's just the way the babies are going to be. Maybe mom is obese. That's going to probably trigger the baby to be obese because mom's probably going to have more nutritional intake, which is going to give the baby more fat. Maybe mom's had multiple babies. Congenital disorders, we're not really going to go into those kinds of things, but these are the main things. Maternal gestational diabetes, all the babies in the families have been large. So complications, are we going to be able to deliver a 10-pound baby vaginally? So there's a good chance that this mom might be a cesarean delivery. Sometimes these babies are breech presentation or shoulder dystocia because their head gets through, but then the body can't get through, and their chest might be bigger. Most of the time, if the head comes through, the other body's going to come through. However, every now and then we will catch those shoulder dystocias where the head comes through, but for whatever reason, the baby's shoulders are bigger than the head, which does not happen 95% of the time. Most of the time, if the head comes through, the shoulders are going to come through too. But we have to always think about birth trauma. If we do deliver that baby vaginally, we got to think about, skull fractures, especially if we're having to use forceps or something like that. Breaking of the clavicles. They might have the brachial plexus injury or Erb's palsy where they come through and their neck, we've pulled all the muscles in here in the neck. Sometimes they'll get Erb's palsy and this one arm will not work. So we have to always think about that. So what are we going to do for these large for gestational babies? We're going to monitor their vital signs. We're going to look for hypoglycemia. That's going to be our 2 biggest things that we're going to do. So we're looking for vital signs. We're looking temperature. We're looking respiratory. We're looking cardiovascular. We're monitoring all that. We're looking for hypoglycemia. So we're looking for blood glucose. We're going to document any birth trauma. Make sure we get that documented right away. Help family bond and help the babies do what they need to be doing to be successful. Okay, so let's talk about preterm babies now. So now we're going to talk about preterm babies. Preterm babies are born less than 37 weeks. We have micropreemies. These guys are less than 1,000 grams. 1,000 grams is 2 pounds, 3 ounces. Late preterm is going to mean that they're born between 34 and 37 weeks. So between 34 and 37. So a lot of times when these babies are born, their organs and their systems are really not fully developed, and they're not ready to take over doing what they need to do outside life. So they're not going to survive unless they have intense care. So most of these babies are going to be in the NICU for a period of time. If you have a baby born at 34 weeks, and whatever their due date was, that's typically the date that they will come home. They may come home a week or two early, but if their due date, let's say their due date is August 1st, and they were born 8 weeks early, so they were born the end of May, that baby probably isn't going to come home till the end of July, just because they need that intense care and we need to monitor them. So what are some contributing factors for preterm? Well, a lot of times we don't really know what causes it. Sometimes babies are just born early like that, and we don't always know. But sometimes it can be maternal lifestyle. It could be, drugs. So unfortunately, we're seeing a lot of that now with drugs. Maybe the mom's health is poor. Maybe it was poor to begin with when she got pregnant. Maybe she has a poor diet. Maybe socioeconomically she can't afford the food, so she has a poor diet. Maybe her living conditions are very, very poor. Maybe they're living in a situation where there's multiple people living together, and mom's just not taking care of herself like she needs to. Maybe mom's working more than she needs to. Low income. A lot of times low income just because they don't see the value of prenatal care. They don't always understand the importance of the nutrition, and they don't always understand the importance of, not smoking, not drinking, not doing these things. If mom has had multiple pregnancies, sometimes that can end in preterm. If mom is over 35, that can end up in preterm. So, but one of the most common factors is rupture of membrane. So for whatever reason, mom's 34 weeks and their membranes rupture, and you're like, that's going to be our number one thing. But a lot of times we don't always know the membranes rupture, and we don't always know the cause. So what's a preterm baby going to look like? So here's what you need to know about a preterm baby. Our preterm babies are going to be little scrawny looking little things. They kind of look like little tiny little rats. And they don't have any muscle. They don't have any subcu tissue. Their head and abdomen are very disproportionately large, so their abdomen's going to be real big. Their skin is going to be super, super thin, almost translucent. You'll be able to see the little veins and stuff in their skin. They're going to have tons of lanugo. When you pull their ear down and hold it, it's going to stay there. They have minimal cartilage, minimal anything. Little boys, their testes won't be descended. In little girls, the labia majora and minora are going to be very open, and you're going to be able to see them. So all that's going to be something that's going to be there. So common complications. You need to know the complications. So a preterm baby, if they're born preterm, they're not out of the woods, because many of these babies will develop these things after they've been born. So sometimes they will develop respiratory distress syndrome. That is just where they don't have the surfactant inside their lungs to be able to breathe good. So we're going to end up doing some kind of mechanical ventilation on them, whether it's CPAP or it's intubation, one or the other. Anytime we do that for that baby, they're going to have heated, humidified air. If we blow cold air in there, that baby's going to get very hypothermic. They're going to get cold stress, and it's going to get worse. So all of that has to be heated, humidified air that's blowing into that baby. Thermal regulation. If you've got a baby that's cold, one of the biggest things you're going to see is periods of apnea. So this is, remember we talked about early on in our newborn, that transition, it's not uncommon for them to have 3 to 5 second periods of apnea. Very common. But if they're really cold you may start to see longer periods of apnea in our preterm babies, like up to 10 to 15 seconds, up to 20 seconds. And if our apnea gets up there very long, we're going to start seeing bradycardic episodes. So they will not breathe, not breathe, not breathe. We'll see a cardiac dive, and then we go mess with them, and everything comes back up. But temperature regulation is going to be a big one. Hypoglycemia, irritability, all of that. So that is our thermoregulation. Maintaining fluid and electrolyte balance. That means giving them the appropriate foods that they need. So that may be TPN, total parental nutrition, because they're not able to eat yet because their bellies aren't ready to take food yet. So we have to make sure we're getting all of that maintained. They have very high need for caloric increase, but they, like I said, they don't have that digestive system that's working. So we may have to give them TPN. Hyperbilirubinemia. A lot of these babies weren't ready to be born yet, so a lot of them end up being jaundiced because they are producing red blood cells, but they're very, very immature and they don't know how to work. So they lyse, and then that breakdown causes our bilirubin. Infections. Infections is a big one. So if we see babies with infections, they usually will have hypoglycemia. Sometimes they might have a patent ductus arteriosus. So remember that the patent ductus arteriosus is the one where it's in the pulmonary artery and it's attached to the aorta. And sometimes that can cause problems because they're born, but they're not supposed to be born, so that stays patent and doesn't want to close. Sometimes just the pressure from coming out of mom and having such a small little skull and the pressure changes can cause interventricular hemorrhages. So we monitor those babies very frequently for interventricular hemorrhages. A lot of times they will get ultrasounds on their skull just to make sure that they're not getting that. That's why a lot of times we tell them we don't want to mess with the babies very much. We go in, we cluster care what has to be done, and then we leave them alone. Because if we keep aggravating them, it increases the pressure, and that can cause them to have an intracranial bleed. So we want to minimize as much care that we can with these babies and let them try to grow like they need to. Retinopathy of prematurity is usually due to increased oxygen levels. So we want to keep their oxygen levels below 99 or below. If you got a baby that their oxygen level is constantly at 100 and they're on oxygen, you need to be weaning them off the oxygen. Lower that oxygen level to keep that sat below 99. Necrotizing enterocolitis, I think we'll talk more about this one here in a minute, but that one can happen just because the baby's digestive system just isn't really ready to work. Jaundice and infection. So we're going to see all of these kinds of things. So treatment's going to depend on any of these things. So if it's this one, we're going to have to deliver the oxygen, like we've talked about. If it's this one, we're going to have to keep them warm. They're going to have to be in a radiant warmer. If it's this one, they may have to have certain types of fluids. We're going to have to give them TPN. They may have to be under a Billy light. They may have to have antibiotics. They may have to have surgery to treat that. So there's all kinds of things that we need to do with these babies. So our treatment's going to be based on what's going on with our babies. So, respiratory distress syndrome. If your baby has respiratory, these are the biggest ones that we're going to see. Respiratory distress syndrome, we're going to have to give them surfactant. So sometimes we can give them antenatal steroids. That's going to be your beclomethasone. Remember, if a mom comes in labor and she's 32 weeks, a lot of times we can give that mom those steroid shots, the beclomethasone, and that will help mature those lungs. Be prepared for resuscitation, because a lot of these babies may not be ready to breathe yet when they first come out. Sometimes we have to end up giving them positive pressure ventilation. Sometimes we have to give them endotracheal ventilation. It just depends. But any type of air that you're going to blow into that baby has to be humidified and it has to be warmed. Interventricular hemorrhaging. So a lot of times we don't even know that these babies have these bleeds because they're asymptomatic. We don't always see it. So prevention is going to be our best bet, giving that baby that quiet environment as much as we can. We already talked about retinopathy of prematurity. Keep that oxygen level down as low as we can. Keep the pressures down as low as we can. What I mean by pressures is sometimes when you have a baby and their lungs, when they're born, their lungs get tight. And so to get oxygen down in there, we have to increase the pressure force it down in there. So the higher the pressures, forcing it down into those lungs can cause problems also. So we want to deliver the best oxygen that we can with the lowest amount of oxygen and the least amount of pressure. Necrotizing enterocolitis. Sometimes it comes on very subtly, but what you need to know, if you got a baby that's starting to be very fussy, and most of the time we're going to be looking at their abdomen, we're going to be measuring that abdomen circumference every day. If you start seeing their abdominal circumference starting to get a little bit bigger and you're like, ooh, this doesn't look good, stop their feedings. That is the first thing you're going to do, is stop those feedings, because that's just going to irritate what is going on inside their stomachs. We're usually going to put them on an NG tube and take everything out of their stomachs. They're going to get IV fluids, TPN, antibiotics. The worst thing that we can happen is if we keep giving them food and it perforates that bowel. Or what actually happens in this enterocolitis is the bowel starts to die. A portion of the bowel dies. So a lot of times we have to go in and remove that dead portion. So we don't like this to happen. We want to catch this very, 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 very early, so those kinds of things don't happen to the babies. Post-term. These are babies that were delivered after 42 weeks. So these are babies that are delivered after 4 weeks, regardless of how big they are. It doesn't matter. They might be 8 pounds and they're 42 weeks. They're still 42 weeks gestation, so that is post-terms. So reasons for post-terms, a lot of times we don't really know. Some of the predisposing factors, if it's the first baby, sometimes that just happens and they just go longer than their dates. If mom is younger, if mom is between 15 and 19, or she's older than 35, sometimes that can cause that. Multiple pregnancies. If mom had post-term babies before, the likelihood of having a post-term is a little bit greater. Maternal obesity is going to increase that. Characteristics. They're very different than our preterm. So I want you to think about what are these babies going to look like. These babies are going to be wide-eyed. They're going to be alert. They are ready to go. They are born as kindergartners and they're ready to go. They're not going to have any lanugo. They're not going to have any vernix. They're going to have lots. Usually will have some subcute tissue. Their fingernails are going to be longer. Their skin is going to be very dry, very cracked, peeling, all that kind of stuff. They might look real long and kind of thin looking. So they're going to look very different. Remember our preterms, they're going to have very thin skin, lots of lanugo, lots of vernix. These guys are going to have no vernix, no lanugo. Their skin is going to be very dry and cracked. You're not going to see no veins or anything like that in these guys. Okay, so potential complications. Our biggest one is, they're ready to be born, so they're going to poop inside and they're going to get that meconium aspiration. Hypoglycemia, their sugars are going to be low. They might have polycythemia, where they have lots of red blood cells. And sometimes that polycythemia can be due to intrauterine hypoxia. So what happens with that is, if the babies are hypoxic, maybe the placenta hasn't been giving them the nutrients that it needs. So they have hypoxia because they're not getting the oxygen that they need. So their little bodies are saying, well, if we're not getting the oxygen, we better produce some more red blood cells, because we need those red blood cells to circulate our oxygen. But there's no oxygen to circulate. So they just keep producing lots and lots and lots of red blood cells, but there's no oxygen to get it. And so their body keeps signaling to produce more. So they get lots of red blood cells. So what happens when the baby's born? They have all these extra red blood cells. So jaundice could be a big problem. So that's what happens with that. This puts those babies at risk for cerebral ischemia. So if those babies aren't getting the oxygen, then the brain's not getting it, the lungs aren't getting it, the liver's not getting it, the body's not getting it. So all those kinds of things can happen. So, and think about it, if we have lots and lots of red blood cells, our blood gets thicker. So we can have that thick blood. So how do we treat this? Well, prevention is make sure that we prevent these post-term babies. Look at ultrasounds. We're going to monitor that fetus. Remember that fetal well-being. How do we monitor those babies? We might do biophysical profiles. We might do non-stress tests. We might do kick counts. We might do all of those kinds of things to make sure that our baby is healthy inside mom. So nursing care, when these babies are born, these babies that are going to be the ones that are going to suck down that 2-ounce bottle, and you're going to be like, oh my. Ooh, they just took that right down. But we want to make sure we observe those babies because they're going to be so hungry. They're going to be like, eat, eat, eat. But we want to make sure that they don't aspirate. So we look for those kinds of things. Monitor that blood glucose because that glucose could possibly come down. Look at their thermal regulation, blood levels. So we might draw a CBC to look at that red blood cell level. Look at their cardiovascular status. All of that kind of stuff for those parents. So now we're going to look at acquired disorders. These are things that the baby can acquire after they're born. The first one is a pretty common one that we see pretty frequently. It's called transient tachypnea of the newborn. And what transient just means it's a short period of time, but it usually occurs that first few hours after life. So it's usually going to kind of disappear around day 3, but it kind of makes nurses a little nervous when we have this happen. But this is when their respiratory rate's going to be over 60, and it's going to stay over 60. So for whatever reason, this is where their body did not absorb that fluid when they were born. Now, the biggest reason that a baby would not absorb the fluid when they're born is because they're born by a C-section. So remember when a baby comes through the birth canal, it kind of squeezes those lungs and it through pressure, forces that fluid out of those lungs. So we don't get that as much. But if they haven't had that and they've had a cesarean section, then that hasn't happened. So we see these babies with a little bit more fluid in there, so they're going to have that tachypnea a little bit more. So we see this transient tachypnea in our C-section babies, our premature babies, our small for gestational age babies, if mom was a smoker, mom was a diabetic. So clinical manifestations, what are they going to look like? They might have a little bit of mild respiratory distress. So they might have, maybe their respiratory rate is 70. They have a little bit of grunting. They might have a tiny bit of nasal flaring. They might have problems feeding because they can't suck and breathe and swallow at the same time. And so we might have to look at things like that. So how do we treat that? Well, it depends on the age of the baby. You know, if it's a term baby, that we're going to do something different with that baby than we do a 35-week baby. And what is their overall status? What's the history of their birth? What was the history prenatally? What's the extent of the distress? If it's minimal distress, we're going to do minimal stuff. But if the distress is getting worse, then we may have to do more interventions. We might give them IV fluids. We might give them gavage feedings because remember, if their respiratory rate's over 60, we really can't feed them orally. We're going to have to give them gavage feedings or whatever. We might have to supplement oxygen. Maybe they're going to be in a hood. You know, maybe they're going to have a little nasal cannula. You know, what are we going to need to do? So nursing care, basically it's just supportive. What do they need to have done? Monitor their vital signs. Look at their oxygen saturation levels. Remember, we want their sat levels to be, we want them to be 100, but if they're on oxygen, we're going to lower that oxygen. We're going to give them IV fluids, help parents understand what's going on, let them know that this is something that can happen, and usually goes away. So meconium aspiration. This is where the baby develops respiratory distress after inhaling meconium mixed with amniotic fluid. So they have aspirated that while they were in utero, or they did it with their first breath after birth. That's why we want to make sure that we suck those babies out really good if we know that there's meconium aspiration. And we're going to know that is when they're, if we have to rupture their membranes and they come out kind of green looking, that's going to tell us that that's probably meconium stained. Or if the mom comes in and she told us that, well, it was really a weird color, it was kind of green, be anticipating those kinds of things. So contributing factors are things that are going to make a baby have meconium aspiration syndrome? Well, the first one, if the baby's been in distress for the last 6 hours, mom's had a very difficult delivery, sometimes that causes the babies to go ahead and have a stool inside mom. But other factors could be like maybe mom has a history of diabetes and hypertension. Those throughout pregnancy have stressed the baby, so it's not uncommon for them to have a meconium. Advanced gestational age, poor intrauterine growth. All of those are kinds of things that can happen. So what are you going to see? If that amniotic fluid is kind of green or greenish stained, I'd be thinking about that. Maybe the baby's having difficulty getting their breaths after they've been born. Their APGAR scores were really low. They got tachypnea or apnea. They're not breathing at all. They got retractions, grunting, nasal flaring, cyanosis, all of those kinds of things. Well, how are we going to know that they have meconium aspiration syndrome? Well, the way that we're going to know is we're going to do a chest x-ray, and it's going to show all that haze inside that lung tissue. So treatment, before the baby comes out, as soon as the head comes out, the doctor's going to suction their mouth, and then he's going to suction their nose. So they're going to suction all of that first. We're going to monitor that oxygen therapy. Sometimes we have to give them assisted ventilation, like our endotracheal tubes. Sometimes once we've established that they're in severe respiratory distress, we may have to do like even tracheal and bronchial suctioning. We may have to even do that kind of thing. So we'll usually also give them antibiotics because it's setting up some type of a pneumonia in there. So nursing care still, sometimes these babies can be very, very sick. A lot of these babies will be transferred to the NICU for close, more one-on-one care. Make sure we keep them with adequate oxygenation, keep them warm. They're going to be under a radiant warmer. Respiratory support, medications, oxygen is ordered. Wean them off the oxygen as quick as possible as long as they're tolerating the weaning. SIDS. SIDS is another one that we have to think about. We call it sudden unexplained infant death. Now it's called SUID. We still call it SIDS a lot. But it's an unexplained death. So we don't really know what causes these things, but usually these babies are relatively healthy, and they're usually younger than a year. And a lot of times they will do an autopsy and they can't really find anything wrong with them, and they will just say that it was, sudden infant death syndrome, or, they'll say something like that. But SIDS is the leading cause of death in infants from between 30 and 365 days. Most of the time, if SIDS is going to occur, it's going to occur in that first 6 months. But there's a lot of theories about SIDS, but we don't have anything that's 100%. We know this is what happens. So usually it's between 2 and 4 months. It's going to be greater if we have a low birth weight or we have a preterm baby. Males are a little bit more apt to have it than females. Minorities are a little bit higher risk, and socioeconomic groups are a little bit higher risk. Moms that are younger than 20, smokers, drug or alcohol abuse. If we keep the babies on their belly, they're more prone to it. Sleeping surfaces, maybe they're sleeping on next to their mom on pillows or something, that's going to cause that. So now we start teaching our families, and it's part of our routine assessment that we do with our families, is teach them about the babies have to sleep on their back, for the first year. Make sure that there's no pillows, bumper pads, stuffed animals, nothing. The only thing nothing needs to be in the crib with them. We actually put a sleep sack or a swaddle sack on them and zip them up, and that's all they wear for the first year of life. There's no blankets, no pillows, no nothing. No co-sleeping. They don't sleep in their parents' bed. Nothing. Because we have seen that is what increases the risk for SIDS. So clinical manifestations, this would be like what you might see would be rapid it's kind of rapid. You don't really know that it's happening. A lot of times parents will go in there and there's no evidence of a struggle. It looks like they just went to sleep. And the babies were in good health before anything happened. So, but sometimes we can get what we call ALTE. This is apparent life-threatening event. I know from working in the NICU myself, we would have a lot of babies that were premature, and a lot of these babies would have apneic episodes. And that's just part of being premature. But I can remember seeing some of these babies that, even a couple weeks before they were going home, we had them on monitors. And they would be on a monitor and they would be having periods of 20-second apnea. And what we would see is these apneic episodes of them not breathing, and then we would see their heart rate start to go do, 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 and get down to like 60. So we would go over there and we would shake them, and then they would take a deep breath and it would completely go away. So these are the babies that might go home on an apnea monitor. So the apnea monitor is set where if they don't breathe for so many seconds, usually it's 15 to 20 seconds, we'll set the apnea monitor. We'll also set the heart rate monitor that if their heart rate goes below 80 or above 180, it will alarm. That gives those parents that heads up that if I go stimulate the baby, they may be okay. Most of the time, any baby that has preterm or been in a NICU, they know CPR before they're sent home also. So nursing care, immediate response, a lot of times this is going to be those babies that are going to come in and we're going to work on them, do everything that we can, but they're not going to make it. Allow those parents to spend time with the baby, allow them to take mementos, allow them to take pictures, allow them that grieving process, talk to them about it. Never say everything's going to be okay. Never say, well, you can have another one. Never say anything like that. Sometimes there's not much to say. Be supportive. Refer them to the SIDS Foundation, refer them to a community health, make sure someone's going to go out and talk to them about that. Many times these people are going to be extremely afraid to have another baby. So just make sure we give them the support that they need and the encouragement that they need, because this is going to be a very difficult time for them. Okay, so now we're going to move to acquired things. So these are things that are going to get acquired. One is hemolytic disease. So your hemolytic disease just means hemo, blood, lytic, means like to lyse or to blow up or to burst. So this is also known as uristoblastosis fetalis, which we've talked about that. This is the infant's red blood cells. This is where they break down and they break down and they're destroyed. And a lot of times these babies can have severe anemia. So what happens is these red blood cells are inside the baby, but they're really not functionable, so they can't really carry any, they're not carrying any oxygen, and as soon as they come in, as soon as the red blood cells are made, they're attacked, and as soon as they're attacked, it causes them to blow up. So if the red blood cell blows up, it can't carry oxygen. If it can't carry oxygen, they're going to have anemia. Not only are they going to have anemia, but they're also going to have hyperbilirubinemia because they're going to have too much of that red blood cell that's been broken down. So sometimes these babies can be born in heart failure. There can be brain damage from hypoxia, because think about it, if there's no red blood cells, there's no oxygen to circulate. So then they get hypoxic. And sometimes these babies can be born very, 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 very ill. So causes. Number one cause is an Rh incompatibility. This is where mom is negative, baby is positive, and mom has produced antibodies that when these antibodies are there, these antibodies that mom has produced go over to the baby, and mom's antibodies say, well, this isn't supposed to be there, so I'm going to start attacking it right now. So mom is pregnant and her body's attacking that baby. She might not even know that she won't know that it's happening, but that's what's happening inside there, causing that baby to be extremely anemic, hypoxic, all of those kinds of things. So if that baby has been hypoxic from lack of oxygen, we're not going to be able to make new brain cells. So if those brain cells are dead, they're just dead. So we can have a lot of complications with these babies. Then there's something called ABO incompatibility. This is where mom has O, but the fetus has A, B, or AB. This usually is not as serious as the Rh incompatibility, but they can still be very serious. So how do we diagnose it? Well, we're going to diagnose it by drawing titers to see if mom has these antibodies. We call that a Coombs test. So we look at the Coombs test. If it's a direct Coombs test, we're looking at it from the baby. If it's an indirect, we're looking at mom's blood to check if mom has that in it. So if we do an indirect Coombs test and it's positive, that tells us that mom has antibodies against the red blood cells of the baby. If baby or direct Coombs is positive, then we know the baby has those antibodies in its body, causing that problem. So we diagnose that with amniocentesis, and again, we're looking for those antibodies, those Rh positive red blood cells in that newborn. We're looking for that direct Coombs test, looking directly at the baby. Indirect is going to be mom. So we look at the Rh and ABO typing. We're going to look at hemoglobin levels. We're going to look at red blood cell counts. We're going to look at bilirubin levels. We're going to look at all of that. So sometimes these babies can be, if they're anemic, they're going to be very pale. They're going to be just white looking. They're going to have a lot of edema, jaundiced, enlarged spleen and liver. Sometimes these babies can be stillborn. They can have hydrops fetalis. Many times this is fatal. And they can have severe brain damage because of lack of that oxygen getting in there. Treatment, if it's severe and we catch it and we know it's happening, we can do an intrauterine transfusion where we transfuse negative blood in there to make sure that those red blood cells are delivering the proper oxygen and nutrients to the mom. We'll end up doing a cesarean delivery just because that baby's already been stressed. So depending on the severity, make sure that they're good and hydrated. We're probably going to end up with phototherapy. They're going to be in a NICU, and we may end up with an exchange transfusion right after birth. So the same thing's going to happen. If their blood has that Rh factor on it and they've got a positive Coombs test and we know they have the antibodies, we're going to have to take those bad red blood cells out and give them good red blood cells so they can have good red blood cells to carry good oxygen throughout their body. So nursing care, initial and ongoing monitoring. So we're going to look initially for jaundice, and we're going to continue to do jaundice levels all the way throughout. We may end up with phototherapy. If we do phototherapy, these babies' eyes have to be protected at all times. So you're going to make sure that the eyes are protected. You're going to make sure their genitalia is protected, especially little girls and boys. We're going to rotate them because you don't want them to just stay in one spot, because jaundice isn't just in one spot. So we're going to have the phototherapy, and we're going to move them and turn them throughout it. They do have to keep hydrated because those bulbs will dehydrate that baby very quickly. So they're going to have to make sure they're giving fluids every 2 hours. So we're going to have frequent feedings. That's another way to get rid of the bilirubin, is for them to have stools. So we want that mom to come in and we want her to feed that baby very, very frequently. We want to monitor their temperatures. All of those kinds of things we're going to do to make sure that those babies are staying cared for. So I want you to go back and look at what we're going to do for nursing care for phototherapy. Just make sure you understand what nursing things we're going to do. So these are newborns that come that have, moms have diabetes. So newborns are going to be at risk if mom has diabetes, whether it's gestational or regular diabetes, for serious complications. So they're going to be directly related to how well mom has controlled her diabetes. So mom has to make sure that she's been controlling her glycemic index. That glycemic index just means that what has her blood sugar been over the course of her pregnancy. If she has not been watching her blood sugars and they've been over 300, then that baby's going to be way higher risk than a mom that's been doing really good glycemic control and she's kept her blood sugars between 100 and 150. So these babies are going to be at risk for congenital anomalies. So it's something that we're going to need to look for. So we're going to look really closely at at mom's blood glucose levels before conception and throughout that whole pregnancy. So we're going to make sure we're watching mom's glucose levels. She's probably going to be coming to prenatal visits way more frequently than a regular mom will be coming. So what is these babies going to look like when they're born of a diabetic mom? Usually they're going to be macrosomic. They're going to be very, very big. Their faces are going to be very big and pudgy, and they're going to have big chunky cheeks, lots of subcutaneous tissue. They're going to be hypoglycemic. So right away, as soon as these babies are born, within the first hour, we're probably going to start checking their blood sugar levels. A lot of times babies that are born of diabetic moms, their lung maturity is not as mature. So a lot of these babies end up with respiratory distress symptoms, or they have other problems with the respiratory. Sometimes they will have preterm deliveries with these, so we're going to be watching those babies a little bit closer. Sometimes they don't transition pulmonary. The cardiopulmonary transition is not as good. These babies will end up with a little bit of oxygen. These babies might end up with a little bit of CPAP. They might end up in a little bit of respiratory distress. So we got to look at all of that stuff. We also going to look at, just remembering that these babies are also going to be at increased risk of developing early onset diabetes in their adolescence and early adulthood, just because mom had it. So nursing care for us, careful observations. Make sure you're watching that baby very, very closely. Early and frequent blood glucose checks. I would rather go ahead and check their blood glucose than not check their blood glucose. If you need to do a blood glucose on them, we have little heel warmers, so you can put the warmers on their heels. That way we don't have to milk the blood or anything. We put these warm things on their heels. That way it brings that blood supply to the heel and makes those sticks a lot easier. We can use these little warm packs for heels, or we can take hot water, wrap it in a washcloth, wrap it around their leg, anything like that to help get those blood sugars a little bit easier for the baby. Early feedings. So these babies we're going to start them in early feedings. I know they're big babies, and you think, oh, this is a big baby, they should be fine. But they're not. These babies are going to get hypoglycemic very, very quickly. So they need to feed early and frequently, and they might have to have an IV for glucose. It's possible. So the biggest things we're going to watch for our babies with diabetes: hypoglycemia, respiratory distress, and then we're going to intervene as needed. So think about respiratory distress. Always be looking for that tachypnea. Always be looking for nasal flaring. Always be looking for all of that kind of stuff. Monitor their electrolyte levels, cardiac function. Check for any signs of birth trauma, because these babies are going to be bigger. So these are babies that are born with moms with substance abuse. So fetal alcohol syndrome is where mom has been drinking throughout the pregnancy. It's been crossing the placenta barrier, getting into the baby. Baby will exhibit withdrawal symptoms during those first few hours after delivery. These babies usually appear to look a little bit different. This can appear when mothers who have had chronic alcoholism, or moms who's had low to moderate consumers of alcohol. So it doesn't have to be your moms that have drank every day. These can be moms that they've drank consistently throughout their pregnancy, but maybe not that much. They recommend that moms stop drinking 3 months prior to pregnancy. So this pre-pregnancy would be good to come in and talk to their doctors 3 or 4 months before they choose to become pregnant. So what are we going to see? We're going to see withdrawing symptoms. They're going to be very hyperactive. They're going to be very irritable. They're going to have trouble sleeping. They're going to have tremors, seizures, all of those kinds of things. Fetal alcohol syndrome, these guys just look very different. When they look very different, they might have, certain things about their ocular. Sometimes they have this flattened bridge across their nose, and they have this ocular weird looking stuff. These babies are very prone to respiratory difficulties, hypoglycemia. So all of the things we're going to have to monitor afterwards with those moms. So nursing care. Well, the number one thing about this is it was preventable. It should have been preventable. We could have had societal interventions, proper screening. Start talking about this early before people get pregnant. Start educating them early on so they understand the complications with it. If you look on the back of any alcoholic beverage, it tells you you should not consume this when you're pregnant. So we are giving them education, but sometimes they're just not listening. So for the newborns, nursing care, supportive interventions, swaddling, keep them wrapped up so they feel tight and secure, decrease sensory stimulation. Don't give them a bunch of stimulation because that's going to cause them to be more irritable. Give them that quiet, dark environment while they're withdrawing. Make sure they're getting adequate nutrition. I&O is important. Make sure you encourage parents feeding and bonding. And we stay very non-judgmental during the process. Neonatal, this should be neonatal. Neonatal abstinence syndrome. This is where the newborns are addicted to whatever substance mom had during pregnancy. So they're going to have the same type of withdrawals that mom would have with these. So what we see is severe irritability, tremors, restlessness, hyperactivity, hyperreflexes, increased muscle tone, tachypnea, vomiting, seizures, all kinds of things afterwards. These babies are very, very, very uncomfortable when they're born. So what are we going to do with them? We're going to provide physical and emotional support to the babies, any type of medications that will assist with their withdrawals or any type of seizure activity. I know few babies that we've had born with meth, we've had to give them morphine every 3 hours to help with their withdrawal symptoms. So sometimes holding them, rocking them, swaddling them. Sometimes we've even had the nurses put on those carriers and carry them around all the time just because they're so irritable. Minimize their stimulation. Try to keep their environment as minimal as you possibly can. Watch their respiratory system. Make sure that they're getting adequate ventilation. Frequent feedings, supplemental fluids. Make sure you're non-judgmental towards the mother. I mean, I know that you're thinking, but it was preventable. Yes, it was, but we have what we have now, so we have to deal with what we have and try to remain as non-judgmental as possible. Okay, so these are babies that are born with an infection. So these guys are going to be at more risk for it because they have a very immature immune system, so they're going to be more susceptible to infection. Sometimes this infection can be prenatally, and they're bringing it with them. Sometimes they can get it during delivery. Sometimes they can get it, well, prenatally would be before they become pregnant. So prenatally might be a congenital syphilis, a congenital, gonorrhea or a chlamydia, something like that. Intrapartum means while they're pregnant. So they develop an infection while they're pregnant, or they get the infection while they're pregnant. After birth, it would be an infection after their birth. So we see those infections, chlamydia, gonorrhea, group B strep, hepatitis, herpes, HIV, all of those types of rubella, staph, all of those infections that we looked at the torch. Remember studying about torch a long time ago? So sometimes these babies may not demonstrate all those symptoms that you think that they should. So what you're going to look for a baby that's not eating good. They're very lethargic. They have poor sucking. They're very pale. They might even have their temperatures very unstable. Maybe they're like 95, 96. We can't get them to get their temperature up. They're lethargic. They just don't look right. Something is not right with them. They're having periods of apnea. This is going to take close observation on nurse's part. So we're going to look at some testing. So we're going to look at their blood. We're going to look at their urine, cerebrospinal fluid, any other labs that we can do to rule out whatever type of infection that they have. So treatment, antibiotic therapy, IV fluids, support the respiratory system, and any other supportive measures. I've probably seen more babies die of group B than I've seen die of other things. And it's just, sometimes these babies just can't fight these infections off. So nursing care, you're always going to go back to your nursing process. What assessments are you gathering? What, when you think about, think about what am I seeing? If you've got a baby that's very lethargic, they're not wanting to eat, their temperatures are very low, you're noticing that, they're not looking right, report that. Don't sit on it and go, well, maybe it's just transition. No. Go let the doctor know. I would rather get some lab work and get something done than have something bad happen. Okay, I know that was very long. I hope you took a couple breaks through it, but that is the end.